Thank you for coming. I hope a lot of you defected from other sessions. We are really lucky to have an amazing lineup of speakers today. I am not one of them, and I don't want to use any more airtime than I already have, so I'm going to turn it over to Emily Oster, and we're going to hear some awesome 5-minute research talks.
Okay, so thank you guys. This is probably the shortest amount of time I've ever had to give a talk, so I will just talk super fast. And good luck. Okay. All right. So the motivating issue in this research is that a lot of people are overweight. In the U.S., about 2/3 of adults are overweight. That means a BMI over 25, and a third are obese. That's a BMI over 30. And there are a lot of negatives to your health in being overweight. Here are a few. And there's a sense in which, like, this for an economist is sort of quite puzzling, because it seems like, whoa, I should just eat less. And you know, I don't know why you're not optimizing. And this is a sort of more general issue. It's something that I think about in a lot of contexts. You know, why are people not always taking the optimal choices about their health at all moments? Okay, so some options are they don't care about their life. That would be like one economics option. They have no idea how to improve their health. Or a sort of more perhaps nuanced view, which is that, like, they struggle to change their behavior on some of these domains. And so, Katy, stop working. It's something. Okay, there you go. All right, so this I'm basically going to show you some data to try to get at some of what's going on around people's choices and start to suggest some things that maybe are kind of could be going on, and you'll see where we go. So when you think about sort of what are some approaches to the problem, well, one thing is you could, like, ask people, why don't they lose? If you want to understand why people struggle to lose weight, you could be like, why don't you lose weight? So some problems with that include they don't know why they can't lose weight. They're just going to tell you the things you want. Well, I really want to lose weight, but it's really hard. It's this, that, and the other thing. Or, you know, particularly there's an issue if you're trying to get people to answer this question, that you're going to, like, select in people who are kind of particularly weird and particularly want to lose weight or struggling in some other way. And I would say this is also a problem with a lot of diet studies, right? So who is going to a diet study? It's somebody who's tried to diet like 1,000,000 times before and they can't do it. Now they've come at last to this diet study. I don't think it's so puzzling that none of those work. What kind of people are in them? The people who are already thin, they don't want to be in your diet study. Okay. All right, so today I'm going to basically try to do something that's kind of totally different, looking at people who are not in our diet study, who are just like people out in the world, and look at what happens when you tell them something about their health that basically is like saying you should lose weight. So the particular data I'm going to use is a data set that economists in industrial organization like to use for such topics as things about ketchup and its pricing. I am not going to study the pricing of ketchup. Instead, I'm going to study health. But the data is the same. So it's a panel from Nielsen. It's basically a scanner data panel, where they tell people, they give people scanners, and they're supposed to scan everything that they buy at grocery stores and tell you everything that they do. And I have, like, UPC level data for, like, many people on exactly what they have bought at all different times. And so you may be wondering, how would you know if they had any health news? And what I'm going to do here is I am going to look at people who don't ever purchase test strips, and I'm going to look for purchases of diabetes products in the data. And that's going to be the identification. I'm basically going to say, let's look at a bunch of these guys. All of a sudden, they start purchasing diabetes products. Probably they got some news about their diabetes. Let's see what happens to their behavior. Okay, so here's the graph of the paper. Here it is. Here's the change in calories after diagnosis. So actually in the first month, they don't do much. And then in subsequent months, there is a decline. How large is this decline? This decline is about 1.5% of the household's calories. Okay, so if you aggregate that up, that's about 50 calories a day. Okay, so you tell somebody they have diabetes, and they have a sustained, statistically significant reduction in their calories, about 50 calories a day. That's like a half a soda. Okay, that's actually enough to lose like 8 pounds a year, which isn't so bad. So you look at what kinds of things they reduce on. This is the kind of thing you can do. You can say, well, it's soda. They eat more nuts. They eat less sugar. But here's the really interesting thing. Here's the heterogeneity across households. So what this tells you is there are some people, that's these guys over on the left, who really are very successful. So like, what is the thing about those people? Let's find them and like figure out what's going on. Here's one aspect of those people's success, and this is the last thing about this research I'm gonna say. What we look at here is how concentrated are people's diets. So I'm gonna identify people who basically a lot of their problem is with one food. So people over here to the right in this graph, those are people who like 50% of their calories are like in Kit Kat bars. Okay, and those people are much more successful at reducing calories than people who basically eat a little too much of everything. And so this is the end of this research for the moment, but the idea is that we're going to try to push it forward and think about what is it about that what is it about that concentration that helps them reduce. And so one of the things that we're thinking about is like maybe when most of your problem is in one thing, then you can actually just have a rule, which is like don't eat so many Kit Kat bars. And that might be easier to follow than some more standard advice. And so the hope is with the next steps of this, that we're actually going to try to test that in the world. Thank you.
All right, so I'm going to show you some work that we've done that speaks to this problem, the problem of out-of-control sizing when it comes to soda sizes. So these here are the sizes from McDonald's in 2013. Incidentally, since then, the sizes have creeped up even further. 2013 is noteworthy because this is the year when former New York City Mayor Bloomberg's soda size restriction policy would have taken place. And that would have prevented restaurants from serving sugary drinks in containers larger than 16 ounces. Now, we know that this policy was very controversial, and in the end it was overturned, but since then, other jurisdictions have been interested in this and other policies, but despite that, there hasn't been any empirical work to date on what the impact of such a policy might be. So what we did is we conducted a series of studies to try to understand, first of all, what are some ways that firms might implement this policy, because there are some degrees of freedom in how they could implement it, and given those implementations, what effect would they have on people's behavior? So I'm going to show you two possible implementations, 3 studies. I'll be really quick, I promise. Okay, so the first possible response that we looked at is bundling, and that simply refers to taking the same amount of soda but apportioning it into 2 regulation-sized cups. So yeah, it's sneaky. So this it would comply with the letter of the law, but it really goes against the spirit of the law, so you might think that this implementation might not help people make healthier decisions. Now here it's important to distinguish between purchasing and consumption. So for consumption, we know from the psychology of eating and allied fields that if you put food in front of someone and you divide that same amount of food into 2 containers, you're going to consume less than if it's in 1 container, because when you finish 1 container, it's a cue that it reminds you that you're eating and maybe you shouldn't eat so much. But when it comes to purchasing, the prediction is a little less clear, right? So it could be that this bundling induces like a 2-for-1 deal mindset and increases purchasing. On the other hand, what we know about consumption norms, that people have strong senses of what an appropriate serving size is. An appropriate serving size for me is 1, not 2. So that might actually curb purchasing. Okay, so we looked at this question in a study where at the beginning of a lab session with lots of unrelated studies, we let people buy drinks using real money. And we gave them a choice. They could buy either a medium or a large. Now, half of people were assigned to the typical sizing condition. The other people were assigned to the bundled condition, right? So we have the unregulated state of the world compared to the bundled, and the bundled, the large, the 24 ounces is apportioned into 2 containers, and you get both of them. What happens with purchasing? What we found was actually this implementation would be synergistic with the spirit of the policy in the sense that it caused people to buy fewer, to be less likely to buy the large. okay, well, this is great for public health, but if I'm a firm, I may not want to do this because it's going to eat into my sales. So I actually think that a more likely response might be free refills. Well, that's just how marketers would call it. It actually is like price-inclusive refills, so offering as many refills as you want on the largest allowable size. So we tested this. Again, half of people had the typical state of the world. The other half of people was the refill implementation. So for these people, the large drink was the maximum allowable regulation size of 16 ounces, but they could get, and of course the large cost more than the medium, they could get as many refills as they wanted, and all they had to do was raise their hand and we'd be running right over and we'd give them a refill. Okay, so what did this do? Here we found that people were actually preference neutral between buying, a 24-ounce large was just as appealing to them as buying a slightly smaller cup where they'd get refills. What about, because there's no difference, now we can, with internal validity, assess consumption. What did they consume? So here's the rub. People actually consumed significantly more calories in the refill condition, suggesting that this implementation might actually have the unintended consequence of inducing the very behavior we're trying to make not happen. So what we did in a third study is we tried to think of a way, a simple tweak that we might make to make this perverse effect go away. And what we did is we simply inserted a ridiculously trivial transaction cost. So instead of being served the refill, so we reran this study with these same two conditions, and we added a third condition, which required just walking 6 steps to go and get your drink. And what we found is that when we did that, relative to the unregulated state of the world, people consumed, on average, 20% fewer calories. So if you implement it the right way, it can actually be effective. Thank you very much.
All right, I'm going to tell you a little bit about exercise behavior. And I think it's safe to say that our friend Homer here has a pretty typical exercise plan. It begins tomorrow. And the problem is that when we look forward, of course, it always begins tomorrow. And this has motivated my co-authors and I in a stream of studies we've been doing where we're really interested in this question: how do we get and keep our collective Homers off the couch? And to that end, we've been conducting a series of randomized control trials at a Fortune 500 company's headquarters. And in these experiments, we've been randomizing subsets of employees to receive financial incentives for working out at the company gym. And a part of our research that I want to talk to you about today is we've been focused on this question of where should we focus our limited resources? And in particular, when we think about this problem of Homer and the couch, should we really be focused on initiating change? Do we need to get Homer off the couch? Or is it a bigger priority to work at sustaining that change and keep him from getting back to the couch? And so to preview kind of key lessons I want you to walk away with today from my quick time, the first is that what we've found is that jump-starting change alone is not very effective. I'll show you some results on that. And it suggests we need ways to help sustain consistent behavior change. And that's a challenge because sustaining that can be quite costly if we're thinking about things like these financial incentives. So I want to talk about 2 examples from our studies where we've seen some positive effects of what I would call very cost-effective strategies, including self-funded commitment contracts and sporadic incentives. So to illustrate the results, I'll show you a series of these graphs where we show the fraction of employees exercising at the company gym each week over time. And so this first one from the first study shows for the control group a very consistent pattern where 20% of them were going to the gym. And in our first study, the incentive group got offered $10 per visit they made to the gym, up to 3 visits a week for a 4-week period. So that's marked by this 1 month here. And what we can see is that paying them had a big effect. It doubled the fraction of people going to the gym. So money gets Homer off the couch. But when we stopped paying, Homer went back to the couch pretty quickly. So what we found is that people returned to baseline of the control very quickly, and within a few months were indistinguishable. But in this study, we also had a secondary treatment aimed at trying to figure out whether we could generate more sustainable change at a low cost. And for this, what happened is this other treatment group got the same incentive program for this same 1 month, but at the end of the program, they were different. At the end of the program, they were given an opportunity to create a self-funded commitment contract where they could put the money they had earned online and risk losing it if they stopped going to the gym over the next 2 months. Now, there was no financial upside to them, so we would generally think that that should get a low take-up rate. But we found that 12% of people made a commitment contract, and if we look among the people who went to the gym at all during the treatment period, that's over 20%, so a modest take-up rate. But it had a significant effect. During these 2 months when the commitment was in place, it sustained visit patterns quite a bit more than removing the incentive entirely. And maybe more remarkably, we actually see a lingering effect even after the commitment period ends that's detectable even over a year later. So this suggests commitment contracts can be a way of helping sustain an initial behavior change. Then in a second study, we focused very directly on this question about initiating change versus sustaining change by experimenting with how we should allocate a fixed pool of money for incentives. So for this study, we had $160 that we could pay out up to $160 for everybody in the treatment group. And so for one group, which you see here in the red line, we offered what we called a consistent program, and they could earn $10 per visit to the gym, up to 2 a week, over an 8-week period. And we contrasted that with a group where we front-loaded those incentives to try to focus really on moving the behavior change. And we front-loaded by making the first 2 weeks worth $25 a visit, and the remaining 6 weeks worth $5, but the same overall amount of money available. And what we found was that front-loading was very ineffective. So that's the blue line here. And you can see that it doesn't generate a lot more use, and people fall off very quickly. And one final insight from this one, again on trying to motivate more lingering change, we took that constant incentive and worked at spreading it out over a 16-week period by randomizing people to receive incentives in only 8 out of 16 weeks. And we informed them the week ahead of time whether the next week would be incentivized. And we found that that helped smooth out behavior and also seems to have had a better lasting effect after the incentives were over, a modestly better effect. So we shouldn't just focus on initiating change, and we can use some clever strategies potentially to help us sustain change in a cost-effective way. Thanks.
Okay, hi, I'm Gretchen Chapman, and I'm going to talk about vaccination behavior. So vaccination is an important behavior for controlling infectious diseases, but often it fails to achieve target rates. And often when we see that vaccination doesn't achieve the rates that we would like to see, we jump immediately to think about education. We just need to tell people that vaccination is safe and effective. But the argument that I want to make in 5 minutes today is that instead of focusing on changing beliefs and attitudes, we would probably get more effectiveness by focusing on interventions that target behavior directly. So I'm sure that there are roles for education, but today I'm going to be focusing on interventions that target behavior directly. So I'm going to tell you about 4 papers that back up this claim. The last one will be data from my own lab. So the first one is a kind of old meta-analysis from Stone in 2002, where they looked at data from 29 immunization studies. And this chart that I've copied from their paper here shows the odds ratio from different categories of interventions that affect immunization behavior. And you can see that organizational change, so that's a kind of structural change in organizations, that has the largest impact on vaccination behavior. So that's not a kind of intervention that tries to get people to believe different things or educate them. That's changing the way that organization is structured. Incentives and reminders, so those are the sort of more traditional interventions. They didn't do too badly. They were in the middle. And then educational interventions were the worst. Okay, piece of data number 2 is a recent paper that came out from Doug Oppel. This is a correlational study, but it's very intriguing. He compared two different kinds of physician communication styles. One is what he called participatory communication style. So a parent comes in with their kid for a pediatrician appointment, and the physician is like, oh, well, like, what would you like to do about these vaccinations? Like, would you like your kid to have these vaccinations? Like, let's discuss it. That led to that was associated with a low vaccination uptake. And then what he calls a presumptive communication style, where the physician just kind of assumes that, of course, you're going to have these vaccinations. Like, we have some shots to do, like stick out your arm. Like, of course, we're going to do them. Was associated with a much higher vaccination rate. Now, this is just a correlational study, right? So we don't know that the communication style caused it. But my colleague Noel Brewer has just completed a randomized clinical trial comparing these two communication styles, which is, of course, what we need to follow up on this intriguing result. Okay. Piece of data number 3 is Katy's study on implementation intentions, where you have people form a plan to get their vaccination. And of course, what an implementation intention does is it lets the environment take control of the behavior. And in her study, people who were prompted to form an implementation intention were several percentage points more likely to get a flu shot. And then final piece of data is defaults. So in our study, we randomized people to get a letter in the opt-out condition that told them you've been pre-scheduled for a flu shot appointment, or opt-in, flu shot appointments are available, you can make one, or no letter. The letters had a big impact on whether or not you had an appointment for a flu shot. A more modest but still significant effect on whether or not you got vaccinated at the special flu clinics, and no effect at all. Also a high no-show rate for the opt-out. That's kind of a bad side effect of the opt-out condition. And then it had no effect on whether you got vaccinated at another place in the clinic that was not the topic of our letters. Here's another way to look at those same data in a graph. So the blue top part of the bars are vaccination at the flu clinic that was the topic of the letter. The red bar is the vaccination at a doctor's office visit, which was another place you could get vaccinated, not the part of our letters. And then the total height of the bars is net vaccination, which you can see that we influenced by our default letters. And that's it. I'm done.
How are you guys doing? It's just a fantastic amount of information flying at you from all sides. Okay, great. I'm going to talk about broadly about the work that I do on placebo effects in behavioral health, and also present some ideas for what that might mean for your work on behavioral economics. So traditionally, we view placebo effects as some nuisance variable that we need to control for in clinical trials. But a review of the research suggests that these, placebo effects are really not so subtle. And in fact, 60 to 90% of all diseases, so diseases ranging from pain, depression, and anxiety to hypertension, asthma, and cancer, benefit from the effect of a sham pill or procedure. In addition, jumping ahead. In addition, it's not just that you get a placebo, you think you're going to feel better, and you say you feel better. Placebo effects are accompanied by robust neurobiological correlates as well. And importantly, the effect of sham procedures are boosted through the psychosocial context. So things like the price of a pill, or the color of a pill, or the brand of a pill can boost the efficacy of a placebo. So patients who are told that they're receiving a medication that's $2.50 get more healthy or have better effects than when they're told that it's a 50-cent discounted pill. So research on placebos has really just ignited over the past several years. There's actually an entire center at the Harvard Medical School here devoted to studying placebo response. But even in the midst of this attention, I still find it shocking that people still seem to view placebos as some result of some magical or mystical response to a sham pill, Or maybe they're just saying that the drug doesn't actually work. But what placebo response really is a remarkable and robust demonstration of a mindset. In this case, the expectation to heal, to recruit healing properties in the body. So what is a mindset? We've heard this term several times today, but it's literally a frame of mind. It's a setting of the mind through which we organize and make sense of the world. So the ability to make sense of the world through our mindsets is natural. It's part of being human. But the mindsets that we choose are not inconsequential. They play a dramatic role in shaping our health, our performance, and our well-being. So let's think for a minute about how placebo effects or mindset effects might influence behavioral health. So think, just take a moment to put up some images in your mind of what you think about when you think about getting good exercise. Okay? So I don't have time to solicit your thoughts, but many people have images like this. You think getting good exercise means going to that aerobics class or sweating buckets in a gym or biking hundreds of miles on a cycling bike, or maybe it's hanging from the roof in some latest fad fitness class. Now, all of these are ideas of what it means to get good exercise. What we found in our research is that these mindsets about what it means to get good exercise matter. This was a study I did with Ellen Langer. We found that women who were working hard in hotel rooms, getting an extraordinary amount of exercise but didn't view it that way, didn't seem to be reaping the benefits. We know that because when we shifted their mindsets, we told them, hey, you're getting good exercise, your work is good exercise. That actually resulted in lower blood pressure, a drop in weight, an improved body image, and job satisfaction, independently of any changes in behavior. So what about mindsets about diet? What does it mean to eat well, right? Here you might think of low fat, low sugar, low taste, right? What we see is this is the image of what it means to eat well, but what we found in our research is this mindset also seems to matter. We know this because we gave people the same exact milkshake at 2 time points, but we gave it to them under different labels. So at one time point, we told them that this shake is a sensible shake. It's a light and fit diet shake. What we found was that had a lower, less satisfying effect and actually changed their gut peptides response to the shake. When we told them that that same shake was high fat, high calorie, they had a greater reduction effect on ghrelin, which relates to physiological satiation. And lastly, what do we think about when we think about stress? We think it's going to kill us. Why? Because that's what public health messages are telling us. But this, too, has an impact on our response. So in a series of studies we've done, we've shown that when people can be primed or inspired to think about the enhancing effects of stress, the effects are far more beneficial on our health. So when we think about nudging behaviors, let's not forget about the whole purpose of changing behaviors in the first place, which was to change our health or our happiness or our productivity. When we think about nudging behaviors, we also need to think about how those nudges influence our mindsets and begin to work synergistically so that we can harness our mindsets as well as our behavior change to improve our health and well-being. Thank you.
All right, the biggest change in the U.S. healthcare system over the last 8 or so years has been Obamacare, but consistent around that same time, another big change has been that for people who have health insurance in the United States, more of us are spending more money out of pocket when we receive medical care. And this is a very traditional economic approach to how to lower healthcare spending and maybe even improve consumer decision making, give people skin in the game, and they'll become savvy consumers of healthcare. The problem with that is the consumer in healthcare, let's say, is the patient, but the decision maker in healthcare isn't always just the patient. It's a very complex decision-making environment. And I want to look at that specifically when money's on the line. And there's several problems with how the market works in the United States. One is it's often impossible to find out the price of healthcare at the time you want to receive it. even harder to find information on the quality of different healthcare alternatives. And shopping isn't just about price, it's about trading off price and quality. And of course, me, the consumer, might be trying to make my decision about price and quality, but my doctor tells me what to do, I probably do what she tells me to do. And so that's a huge issue. And those are not what I'm going to talk about, but they're there. Instead, I'm going to talk about what the final step in this decision, which is what happens when the topic of money comes up in the doctor's office. And so we worked with the company Verilog that has audio recorded over 100,000 physician-patient interactions with permission of both physician and patient. We took about 2,000 recordings of people who had what we knew would be expensive illnesses, that were seeing their doctors who were carrying them for those illnesses. And we looked to see what happened, how often the topic of healthcare costs came up and what happened when they talked about it. So really quickly, healthcare costs come up pretty frequently. 20 to 40% of these interactions, somebody, either the doctor or the patient, would bring up something about out-of-pocket healthcare costs. And when they brought it up, a decent chunk of the time, about 40 to 50% of the time, there was some conversation about how to lower patients' out-of-pocket costs. And it could be switching to the generic form of a pill. It could mean going to that discount pharmacy rather than the expensive pharmacy. It could mean switching an alternative. It could mean getting a PET scan in December, since you've already paid this year deductible off, and not wait till January when it's on you to get that scan. And so you saw doctors and patients having lots of conversations about how to kind of game the system a little bit and lower costs or find the right alternatives. But that was 40 to 50% of the time that they talked about strategies. That meant when costs came up, the majority of the time they didn't talk about how to lower costs. And remember, costs didn't come up the majority of the time. So most of what we have going on here is very little discussion of money. Even more disturbingly, when money comes up, it doesn't always get discussed the way you'd want to be. A patient who said, I know there's a thing out there for that ulcer besides the Nexium, that's so expensive. And the doc says, yeah. We did this medicine for your rheumatoid arthritis and basically completely blew off the topic of this patient's ulcer pill. Or, doctor, what do we need? The Restoril, the folic acid? No, they won't approve that one, the insurance company. I don't know why. Those insurance companies, they don't want to pay for anything. I know. I also need a Tylenol 3. Okay, we do it. There were conversations that went on for minutes where the doctor and patient, they bonded over hatred of insurance company or pharmaceutical companies, and they never got to addressing the patient's out-of-pocket burden. Well, the doctor says, we'll see if the insurance company is going to pay for your genetic test for breast cancer. Well, how much does it cost? The patient asks. Oh, we don't want to talk about that. Well, no, we did want to talk about that. That's why we brought the topic up. There are times where the patients try to, they don't want to be all money-wise. So they go, doctor says, okay, your insurance had no problem paying for it. Well, we paid. Yeah, they paid. They paid well. There was a lot of copay, but that's okay. That's not a problem. The doc says, okay. But if the patient's bringing up their copay, there's a chance it really was a problem. You can't just accept their dismissal of it. There are times where you just find out whether it's covered by insurance and assume that's full coverage, and it's rarely full coverage anymore these days. When you assume generic medicines are affordable, and they're often not affordable, they're getting more and more expensive. You assume that if they get some kind of coupon to pay for a medicine, they're okay, but the coupons only pay for part of the medicine. So what we need to do to improve consumerism in healthcare is we need to get price information, quality information out there. We need to help clinicians and patients discuss costs more productively in the clinic office. We need to make sure that people are paying out of pocket for what they ought to be making decisions about, but when it's urgent care that they need, they shouldn't have to pay out of pocket for it. And we need to make sure they're not expected to do all the work of lowering the cost of the U.S. healthcare system on their own. We need some extra help to get the things affordable. Thank you.
That was amazing. We're actually on schedule, which is even more amazing. I hope you guys can tell why these guys were my research heroes and why I invited all of them. So we now are going to switch gears a little bit. We're going to have two speakers from industry who are going to pose big questions. And after that, I'm going to invite all the speakers to come up and we'll have a panel discussion, first amongst ourselves about what we think some of the interesting open questions are in this space. And then we'll open it up for questions from you guys. Okay, so I'm going to turn it over to Jesse.
All right, thanks. As Katy said, I don't have any answers. I just have questions here. So I'm Jessie Wisdom. I work at Google in the People Analytics group, where our goal is to ensure that all of the people-related decisions made at the company are based on research, data, and analytics. And we've done a lot of, we care a lot about employee well-being, so we've done a lot of experiments, for example, looking at how we can encourage healthier behaviors using nudges and tools like that. But recently, we've been focused on how we can help employees to better navigate their own healthcare, and in particular, how we can help them to make the best decision that for their specific individualized situation. So very broadly, the question we're trying to answer is, how do we help people who are strapped for time to engage with and understand their options for healthcare? And of course, this is not a problem that is unique to Googlers, right? So people today are often strapped for time and don't actually engage with healthcare until they're in a moment of crisis. And so very broadly, at the basic level, this means that we want people to log into the online portal annually and make their decision about their health plan by understanding and engaging with those options. But beyond that, we're specifically focused now on how we can help them to make the best decision when they are in that moment of crisis and they need to make a quick decision. So we know that, Googlers, when they're making these decisions, if they're doing it in the spur of the moment, they're probably not making the best decision. But we also know that by doing so, they could be achieving better health outcomes, better care experiences, and lower costs for both themselves and for the company. So we have a couple of options that we give to Googlers, but what we're finding is that unfortunately, they often default to emergency room visits. So when they perceive themselves to be in a medical crisis, they immediately tend to think of going to the emergency room. And this probably isn't surprising, right? You can think of they may be overweighting the fact that, or the chance that what they're facing is actually a disastrous experience, and thinking, when it comes to my health, better safe than sorry. Also, emergency rooms have been around for a while, right? So in a lot of people's heads, it's kind of the default option for where you go when you can't get in touch with your primary care doctor because it's late at night or so on. So at Google, we do have a bunch of other options that employees can use, but unfortunately, they're often not aware of them until it's too late because they don't take the time to read through and understand them ahead of time. And then once they're in that stressful situation, you obviously can't get them to, log online and start reading through these things. So some of the options include urgent care. So I'm sure you all know what urgent care clinics are, but these are easily accessible in most of the locations Google operates. We also have virtual online doctor appointments, so you can get in touch with a medical professional at any time, and it usually just takes a couple of minutes. And then we have also house calls, so you can actually get in touch with a doctor, have them come over to your house, and it can be pretty much immediately, so within a couple of hours, or you could schedule it for the future. Wow, I'm already at 2 minutes. Okay, so unfortunately, people don't use these, right? And they sound great. I know that I would like to have, a doctor come to my house instead of dragging myself out of bed. And we do everything that we can to educate employees about these options. So we've partnered with a vendor who is trying to bring transparency to the healthcare market. And there's an online tool where Googlers can sign in and search for doctors and get information on quality and cost. And it also tries to surface things in a sort of smart way. So if I log in and search for ear infections, it's going to give me all of the information on virtual doctor's appointments. But unfortunately, as I said, this doesn't stop people from defaulting to the emergency room. So that's one problem that we're trying to help with right now. And then the other thing that we would like Googlers to do is engage with our second opinion program. So essentially, when Googlers get a diagnosis on a medical condition, we have a program where they can get in touch with experts from a variety of different locations. So doctors from Mayo Clinic, from Harvard, from Johns Hopkins, and these experts will take a look at their medical records and give them a second opinion on what they should do. And of course, this doesn't change the the medical recommendation in every case, but in 60 to 70% of the cases to date, the Googler has adjusted their treatment in some way as a result of this, and in 20% it's actually changed their medical diagnosis. So we obviously want Googlers to not just take the word of their initial doctor, but to really make sure that they're doing the right thing. So in conclusion, our goal is to help our employees achieve better health outcomes, not only once a year when they're logging into the online portal to make a health plan decision, but also throughout the year, and how to utilize these services to best match their specific issue with the most appropriate service. Thanks.
Hi, I'm Robert Sahadevan from Humana, the health insurer, and so we've touched on many different things here. I'm going to take a little different tack with this, which when Katy asked for what is some of the biggest things that this group could help in terms of healthcare, we think of it as engagement in your health. That's a very broad thing, but that means something very different to people. And for example, we talked about sort of how insurance companies can make consumerism easier. And one of the things that Humana has tried is to simplify insurance because there's so many different dimensions, out-of-pocket costs, maximum annual costs, things like that. But what matters for people is very different on who you are. And so I come from outside the industry to begin with. I ran the Mileage Plus program for United Airlines for 10 years, which I think of as one of the biggest behavioral incentive programs out there. And sometimes it was financial, sometimes it wasn't. And so I could look at things and look at our customer base. And one of the things we found was there was a group of people who we called self-directed pros. And these people didn't need to talk to a reservations person. They didn't want to check in with a person. What they wanted was to check in online. This is back in the early 2000s, and that was what led to things like kiosks where you can check in on your own, or we were an early adopter of the web and doing all of those different pieces. So in healthcare, what does that mean? We've done things to look at who are the different customer groups that are out there. And so things like we found there are people who are self-directed, meaning that they're self-engaged optimists, I should say. I'm mixing up my industries. These people will think about the future. They will invest in their health today and drive a better outcome. And as a health insurer, that's what you want, right? That's what we want for a society. People who are engaging in their health and avoiding these issues, as Kevin talked about, not going over the waterfall. So there's another group, though, that we call them skeptical control seekers, where they don't actually, if they don't think it's their idea, they're not going to take what a nurse says or anybody else. Think of my dad, who's a physician, my sister, who's a surgeon. These people think they know everything, and they do in Medicare, right? Similar to my old life. If you talk to a pilot, very self-assured. But those are a big part of the population. And so when we think about, we have a chronic care program, and we want people to engage in it, we want people to, if we do the telephonic program, people usually drop out in 1 to 3 calls. So it's very important that we have that nurse or that customer service person engage with them very quickly. And so we've used these techniques to sort of say, this is the type of person on the other end of the line. Speak to them in ways that will engage them quickly. So we've done different tests. One of those pieces was we have, you can imagine in insurance that many people think of us as skeptical. One of the things that internally people think about is people don't trust their health insurer. Well, yes, there's a segment of the population that will never trust their health insurer. But there's also populations that their doctor doesn't have the time. We describe those scenarios where they're not really taking the time to explain things. We are seeing from all of our data that they probably have different issues, and we need to basically get across to them what they could do to coordinate the healthcare system, or just reach out to us and we'll help you do those things. But it depends on who you are and how we approach it. And so the message that I wanted to get across to this group on how you can help us is really, we think about every member as someone that we want to help, but we don't have the resources to invest in everybody in the same way. So how do we differentially invest to make sure that we get everybody engaged and find out what the right treatments are? Because as what I put up on the slide is, when I think about when I came to this industry from other consumer industries, the segmentations are really simple. It's based on male, female. It's based on your income level and a few other dimensions, right? It's not the same thing I was used to in other places, and so that's what we're trying to bring to the industry. So all of these different interventions or modalities that you're all working on, that's great, and we want all of that. And then what we're doing is trying to figure out, who does that work for? At what time does that work? Because that's the biggest thing that we can try to do, is tailor what we do to get people to be healthy. And so, for example, we have done interventions. Medical adherence is one. Many different things out there. And when we've looked at some of these things, you would say this didn't really work when you did a control test. When you start taking it apart by applying that intervention to specific groups, it showed that it worked for 1 or 2 groups, but the other 8 groups swamped it. and it was not something that really showed its benefit. So we're going and trying to understand what are the interventions that work for specific types of people when, and that sort of playbook is what we're building, and that's how you can all help us help people. So with that, I will end on that.
All right, so we are spot on time. In fact, even a minute or two early, which is awesome because it means we're going to have lots of time for a great panel discussion. So I'm going to invite all of our speakers up to the front to these lovely black chairs. Feel free to bring your water bottles, and I'm going to do my best for a few minutes to moderate a discussion about big questions that people in this room might want to be answering. So I'm going to sort of start by opening it up to the folks who haven't had a chance to talk about big questions. So we heard from Robert and Jesse about big questions. I'm interested to hear from the academics who presented what you guys think the most exciting big questions are that are unanswered. And I'll let you sort of volunteer who wants to go first. I will call on someone if no one does because I'm at a business school, but I'm hoping we'll have a volunteer.
I'll volunteer.
Yay, Leslie, thank you for saving everyone from the cold call. And then we can pass the mic down and hear what people have on their minds.
A couple things come to mind with respect to topics that I think are underexplored but important to explore moving forward in the domain of behavioral nudges, whether they apply to health or other types of behaviors we want to change. One is the timing of nudges. So I, for one, when I design interventions, I think a lot about what I'm going to do, like what the intervention is. And what I think that I often neglect is the timing, like when are we going to roll this thing out? And so I think there's some work that could be done there in thinking about, like it could be that maybe a mediocre substance-wise intervention, but with impeccable timing, like something, if you're trying to get someone to sign up for a health program, for example, New Year's resolutions, timing, huge. It could be that a mediocre, substantively timed at the right time can be as effective or more effective than something that is maybe substantively a wonderful commitment device or program, but not with great timing. And then the other thing that I think could be explored more is the impact of sort of awareness, meta-awareness of nudges, because they're becoming more popular, they're becoming more mainstream, and consumers are knowing more that there are these tools we use. So what is the impact of informing people that we're using these tools on the effectiveness of these tools? One piece of work that's come to mind is Mary Stuffel's work. I saw her earlier in this session. There she is. She has a brand new paper coming out about defaults, when people are aware that we're using defaults, and my general takeaway is that they seem to be robust to awareness, but there's a whole, I mean, that's just one of many nudges, right? So I think there's a body of work that could be done in that vein.
One of the most shocking statistics in medicine that nobody talks about is that in the year following a heart attack, people only take their cardiovascular medicines about 40 to 45% of the time. And I think that reveals a lot about both what we don't know and the limits to what's been tried so far. So while there are a lot of different interventions people have tried that seem to show some promise, I think there's still a lot of very important fundamental questions about understanding why is it that somebody who just had this life-threatening event is choosing not to take their medication, even though it seems like a fairly simple thing to do. That suggests maybe it's not as simple as providers would think. And I think related to that, there's a lot of really interesting questions about how paternalistic should we be? And of course, it depends a bit on who we is. I think people have different feelings about whether it's their healthcare provider versus a health plan versus some other entity, but lots of issues to try to figure out.
I think sustainability is one of the big questions. I just don't know if we've really figured out. We can sometimes get people to do behaviors that they ought to do for a little while, and then you saw your data that it's fading off. I'd love to figure out how to address sustainability. I think in exercise, I don't know that we do enough emphasis on fun. I mean, I don't find gyms that much fun. There's just a lot of weird people in there, and they smell bad. But if it's something that people don't enjoy, it's hard to get it sustained, or they have to be miserable not doing it. And so the other thought, then I'll be done. I'd like to have more like cholesterol pills and things with, I don't know if it's caffeine or something, where when they don't take the pill, they get a caffeine withdrawal headache, and that makes them take the pill or something. So I'd love to, okay, maybe that's not appropriate, but I think we need to really think about how to sustain behavior change.
Okay. So I think one thing, and this alludes a little bit to what you said, is thinking more about heterogeneity across people. That basically, when we think about the population, there are large swaths of the population, probably the people who are the most expensive for health plans and who have the worst health outcomes, where there are a lot of other things going on in their lives that make it quite difficult to sustain some of these behavior changes, and it is likely that for those groups, things like the gym, it's not a feasible option. And so I think when we think about sort of how to target interventions or target sort of how we approach people, I think that there, in some sense, there's probably not enough focus on the bottom, particularly from the cost side, where actually the sort of super user model would tell you that those are probably the groups that are most expensive, and they're probably least responsive to some of the things we do, and sort of thinking about how you get to that area is probably of some significant value.
So I also think this issue of targeting is quite interesting, and maybe sort of two reasons. One, as Emily was just talking about, I think as we start to understand better who can and can't respond easily to these things, I think there are going to be some distributional effects of all of this move towards consumerism in healthcare that we've been underappreciating, that there's a big swath of people who don't respond well as we start increasing costs, and we need to wrestle with that a little bit more. But then I think there's also an interesting challenge in this desire to figure out targeting and heterogeneity more. And it runs up in a lot of social science, social psychology right now, there's this big debate about replicability crisis and low-powered studies. And this is a big problem when we want to get at heterogeneity, because we don't actually have a lot of power in a lot of these studies. And so I think we also need a little bit of a revolution in how we do this type of heterogeneity study. And that may come from big data. There's some new techniques coming out in sort of machine learning, or sort of finding ways to pre-identify these groups, these types, like Robert was talking about, so that we can do some of this, but do it in a kind of rigorous way where we're not going to have a bunch of junk studies 10 years from now.
You've heard me get on my soapbox about placebo effects and mindset effects. I think the biggest challenge that I think could really do a lot for health is to understand how we can harness those deliberately. So we've known about placebo response for a very long time, but done virtually nothing to actively utilize that in healthcare. And as healthcare moves, away from infectious diseases towards chronic diseases, and we learn that now 1 in 2 adults, so 50% of adults have a chronic disease. I reread that every time I say it, because I'm like, could that be right? Our very notion of health, I think, needs to change, because when we ask people, what does it mean to be healthy, most people still continue to define it as an absence of illness. This is in spite of the CDC's definition, which for 70 years has been a complete state of mental, physical, and social well-being. But if we continue to define our health as an absence of illness, and yet 50% of us have a chronic disease, then by our very definition, we're all unhealthy, or 50% of us are unhealthy. That has damaging consequences for our health, just from a psychological perspective. So what can we do as a culture to redefine what it means to be healthy? Maybe we're not going to achieve a complete state of health. Maybe we need to rethink what health is like, make it more fun, make it more dynamic, make it more social.
I would echo the challenge that a number of you already voiced about sustainability, and I would just add to that I think that sustaining health behavior poses different challenges for sort of everyday behaviors like exercise or diet or medication adherence versus once in a while behavior like cancer screening or vaccination, just because the cues for those behaviors are very different. And another challenge that I'll add to the list, or I will phrase it as an opportunity. The social context of health behaviors. I think there's a lot of opportunities to harness behavioral insights to encourage healthy behavior through the social context of behaviors. So social comparison and social support, and doing healthy behaviors for others. Sometimes people will quit smoking for their kids or vaccinate so that they don't infect other people. and I think we could do more with that to exploit the social context in which health behaviors occur to use that to encourage people, to encourage those behaviors.
I am eventually going to open up to questions, but I'm going to selfishly ask one more of this amazing group of minds before turning it over to you, wise audience. The question that I would love an answer to from each of you is, what is a study by someone else that you've read in the last couple of years that you really admire and has changed or shaped the way you're thinking about challenges in this behavioral health space? And could you sort of summarize very briefly for us that one study, or if it's two, we'll survive if it's two, and then we'll all learn from you in yet another way.
So I'm going to talk about placebos again. Okay. Most people assume that in order for placebos to work, you have to be deceived. And Ted Kapchuk, who's the director of the program for placebo studies here, ran a series of studies where he had people come to the doctor's office for IBS or migraines or depression, a variety of ailments, and he had the physicians prescribe them placebos. They said very openly, I'm going to prescribe you a placebo. It has nothing in it. There are no active ingredients. But I want you to take it as prescribed 3 times a day for the next 2 weeks. And come back and we'll measure you again. And what he found was that people taking placebos, taking nothing, knowing they were taking placebos, still improved compared to control groups that not knowing anything at all. And so I think this, opens up our minds a little bit to think what could be possible here. And it, I think, echoes what Angie was saying, what Leslie was saying about metacognitive processes, and how when we're as individuals aware of nudges and aware of mindset effects, we are just emboldened with a sense of, possibility for how we can maneuver our own lives to improve our health.
What was the control group? What was the placebo for the placebo?
Yeah, in that case, it was just a good question. That's a very difficult thing to do in our studies, is figure out what the other control group is. And that one, it was just a no treatment control group. So people with no treatment at all. Yeah.
Okay, I got one. Good. Now I'm holding the mic.
Yeah.
Okay. All right. So I actually, I have like a 15-month-old, and so I don't sleep that much. And I remember this study, but not anything about where it was published or who wrote it. So sorry. So there was a relatively recent meta-analysis about various named diets. Which I think gets a little bit at this heterogeneity idea in a sort of different way. It's basically about like which is the best diet. Should you be on the Atkins diet or the Ornish diet or the this diet? The 2 grapefruit, 1 grapefruit, 12 grapefruit diet. What are those, like, different names? Jenny Craig. There are a lot of them, as it turns out. And basically the conclusion of the study is like all of these diets are fine. They are all somewhat effective for some short period of time, and basically none of them are particularly more effective than the other, and the diet that is good for you is the diet that works. And I think that there's a sense in which this is a broader point than just in diet, which is like if you want people to stick to something, it may be that the issue is the getting them to stick to it, not so much what it is. So there it's like basically if you don't eat as much, then you will lose weight. The issue is not so much is one kind of calorie sort of different in a particularly large way than another, but rather which is the diet that you can do. And I think we could think about that in exercise or a lot of these other behavior things, that it's really like personal motivation that is more of an issue than the sort of particulars of the behavior.
I'll go since I'm holding a mic. So a study I found really interesting, there was a study by Zarek Broke-Goldberg and some co-authors where they were looking at this question that Peter raised in his talk about consumerism and basically giving people a lot of cost sharing. And so they studied this firm where everybody was switched from very generous coverage to coverage where everybody had a high deductible plan. But the firm also gave people money into a health savings account where in theory they could have spent it to access care. And so it was a really nice experiment of what happens when you give people cost sharing. And I thought the really stunning result there was that people dramatically reduced how often they went to the doctor and their medical spending, but really surprisingly in a very indiscriminate way. So they saw a lot of people who had chronic conditions, didn't go to the doctor while they were underneath the cost sharing and the high deductible. And they saw a lot of what looked, at least on the surface, like some pretty inefficient choices about when to pull back on care. And so I thought that was a pretty big wake-up call for a lot of economists who for a long time thought that sort of cost sharing was a good sort of consumer-directed way of making this happen. And it's made me really think a lot more about how that goes.
One I've been thinking about recently is George Lowenstein and others on enhanced active choice. So basically the idea that you can force a choice but use behavioral insights to frame the different choices in ways that are compelling to people. So at Google, we often get a lot of pushback when we try and institute nudges or things like that because they see it as like HR trying to manipulate people again. And so thinking about how we can get people to actually make a choice on their own and what vehicles we have to do that. So for example, open enrollment, which is the time during the year when everybody can go in and pick their health plan. That's a time when we actually have people that are pretty engaged, right? Most people go in and actually do that. And so are there choices that we can feed into that open enrollment platform and frame them in a way that is going to sort of direct people to the choice we think they'd be better off with?
I am blanking on the authors, and I don't have a baby as a reasonable excuse, so I'm just a terrible person. It's in the American Journal of Health Promotion, if that makes it better. So this is a study about it's a calorie labeling study, which in a way surprises me that I'm saying this because in general, I think information provision, telling people how many calories are in something, it's a pretty blunt force tool to try to change their behavior. But this study I really love because it's a beautiful example of it's pretty inexpensive to provide information, at least relative to other things like incentivizing people. And oftentimes you're going to provide the information anyways. So if you're going to provide the information, why don't you provide it in a way that makes more sense to people and has more capacity to move the needle? And so what they did in this study was so the control condition was just standard calorie labels on soda. Bottles of soda in a little mom and pop grocery store. It was a beautiful field experiment. And the experimental condition was they translated this information into how long you'd have to run to burn off that amount of soda. So this is a beautiful example of like, that makes sense. Now I understand how painful it's going to be if I drink this thing. And they found that this was actually, it was effective in reducing the likelihood that people would buy sugary drinks relative to just a standard label.
So I'm going to tell you about the study that contributed that shocking statistic I shared with you a few minutes ago. So Nitish Chowdhury did this really interesting experiment. He got Aetna to participate in randomizing all the patients who were Aetna beneficiaries around the country had heart attacks and randomized them either standard co-payments or getting their medicines for free. And there are two very interesting results, well, several interesting results, but two I'll highlight. One is that among people who had standard benefits, the average adherence in the year following a heart attack to cardiovascular medicines was 39%. If you make the medicines free, it was 45%. And this study, I think, has had a big impact on our work because it's really pushed us to think about the limitations of using benefit design as a tool to get people to be more adherent. Clearly, making services free is not enough to encourage higher rates of adherence, and it's pushed us to think about various ways of making those incentives more salient, to think about plan designs being simpler, and to think about the nexus between provider and patient engagement.
So by read study, I mean read about the study in the New York Times. It's the Biggest Loser study that came out earlier this year, where it just shows that our bodies really fight against weight loss, that once you've had sustained overweight or obesity, you can cut the calories the people your data showed, and you're not going to lose weight, and it's not going to sustain it. And the lessons I draw from that are incentive programs that like punish you with higher health insurance premiums because you don't lose weight are cruel and don't understand biology. That what we should do with people who are overweight or obese is try to keep them from gaining more weight, help them to not gain more weight, and more importantly, help them become enjoyably more active. Because if you're big but you're fit, all right? And then the third thing I draw from it is our efforts to combat obesity should be focused on preventing young people from becoming obese.
I don't want to put pressure on anyone, but is there anyone who hasn't spoken who would like to share a favorite study?
Yeah,
foreshadow one. Okay. You know, it's not published yet, but it's something that we contributed some of our members to, and it's something we worked on with Penn. And I'll let Kevin talk about sort of results if he wants, but the paper will be published soon. The reason I wanted to bring it up was, you know, we talk about sustainability and we talk about targeting, and some of the things that this program was about med adherence, and it was about, you know, are there financial incentives or are there social forces? And this experiment combined all of those things to see if we could drive better med adherence. And so I wanted to sort of highlight that because it's nice to start to see these things that are combining these multiple effects and then being watched in a controlled way, that we can tease out sort of which parts of these things drove overall adherence. And so I think that's a great example of, you know, partnerships when, you know, Justin was talking about the power of things. And that's where, you know, hopefully more insurers and all of us in the industry want to be contributing to partnerships like this, where we're contributing sort of the patients that know some things about them, and then combining it with the experimentation that you're all doing.
All right, I'm always a sucker for food studies. We've already mentioned a few. So Carrie Morowich has a recent paper in my favorite journal, Psych Science, comparing close substitutes for a food that you like but isn't available versus a food that is not a close substitute but sort of in the same category. And people predict that what they'll like better is the inferior but close substitute, but what they actually find more satisfying is the food that's not close but in the same category. So you can't have like the really good chocolate because it's not available, so you think you're gonna want the low quality chocolate, but what you'll actually be more satisfied with is like the granola bar, right, which is still a snack but not chocolate. So you mispredict what you're going to find most satisfying. And they didn't do this in the paper, but I think it would have some interesting implications for dieting, where there's a certain food you're forbidden to have because you're on a diet, so you go for something that is, you can't have ice cream because you're on a diet, so you're going to go for like low-fat yogurt, but then you don't find that satisfying. So then you go and eat something else anyway, and you would be better off just having like a completely different snack that's not trying to be ice cream.
I hope you guys found that as fascinating as I did. Let's give our panelists a hand for all of their contributions. I'm not ending the session. I just felt that needed applause. So now let's open it up for questions from you guys. And I think the way that we have to do this is that I'm going to run around and try to hear you. Oh, right. That I was going to get close enough that I could hear and then restate.
No, I don't think we're going to have a problem hearing them. Talk loud.
All right, talk loudly, folks. Okay, and the woman in the second from the back row, yes, who's looking behind you, yes. Oh, sorry. Elspeth. I actually know you. I'm just seeing random.
I was going to say it's ironic that in a health session I think I've sustained a hand injury from making so many notes, so thanks for that. I was actually going to ask you about how you think about unintended consequences. So, Kevin, when you get everybody to fully adhere to their cardiovascular medication, for example, what if it's a zero-sum game and they just stop exercising? And I guess I'm interested from both the sort of health perspective, but also, when you're kind of trying to work in a world where you're aligning interests with insurers who are interested in, kind of reducing the amount that they're having to pay out.
Yeah, it's an interesting question, and I don't think we fully understand the unintended consequences of a lot of these interventions. If we are able to significantly improve adherence to life-saving cardiovascular medicines, I guess I'd be willing to take my chances that if people exercise a bit less or have less mental bandwidth to exert towards other health-improving activities, that they'd still be better off. It is a bit of an open question, though, one which I think needs to be more systematically explored, particularly if we use financial incentives, but for that matter, if we use any kind of social incentive, social comparison, it draws more attention to particular activities, and it's not unreasonable to be concerned that people may put less effort into activities that aren't being measured and on which they're not getting the same kind of feedback.
Front row. This gentleman whose name I don't know.
Olivier from the World Economic Forum. I got a question. Don't you think that we're making the same mistake as medicine by looking at something sustainable. What if behavior change is not sustainable? And we should look at it in a cyclical way. Timing is crucial, but maybe pacing is even more important. And we should look at what Walmart is doing, for example. They don't have a silver bullet. They don't change the behavior once. They just come back and forth. Just like me offering flowers. If I offer flowers once every year, it doesn't work. If I offer flowers once every day, it becomes too banal and it doesn't change anything. So what about the fact that we stop looking for silver bullets, looking for something that is sustainable, and start working on timing and rhythm rather just sustainability? And there are very, very interesting insights from consumer neuroscience as to when dopamine and the reward system in the brain starts, decaying with respect to the incentives, regardless the nature of the incentives.
When you talk about flowers not working when you give them once a year, what outcome measure are you defining success?
Dopamine rush.
I feel like you're speaks to it. I'm calling on you.
So I thought Katy was going to answer this one. But, so I think this is a great question. I think some of us have started thinking a little bit about this. You could see hints of it in the study I was presenting at the end, where we were trying to do this sporadic incentive, where we're trying to think about turning things on and turning them off. So far I haven't seen a good experiment that tries to do that over a long period of time. I don't know if anybody else knows about those sort of timing. I think some of Katy's work on thinking about these fresh start effects that she talked about in the sort of opening is one of our first best things in starting to think about how would you target and time things. But I think it's this idea of trying to think about how to target and pace is a nice idea, but I don't think we know a lot yet.
Sales in supermarkets.
Yeah, I think you raise a very interesting question as to whether we're trying to hold ourselves up to too high a standard. So nobody's asking the question of, if I put a patient on high blood pressure medicine, if I stop the medicine, will their blood pressure be permanently controlled? It's understood you stop the medicine, the blood pressure goes back up. And in the same vein, a more realistic goal might be, maybe we should try to focus on designing behavioral interventions that, as long as they keep going, have sustained effects, as opposed to time-limited interventions which have sustained effects after we turn them off. That's a much harder bar to meet.
If I could add to that, because we've done some work with Katy in terms of, it's the right notion, if you can talk to them, right message, right time kind of concept. And new diagnosis is a good example of one that likely will work. The point I wanted to make is practicality and trying to get that information back to know what's going on in a consumer's mind. And what's going through my mind is sitting through a panel on poverty, because one of the points that was made was, hey, I know I have to eat healthier, or I need to go see this physician, but with that copay or other things with it, I have to pay for my rent, or I have to pay for just food. And so I'm going to delay this piece. And so as we've tried things around that, it's just a very hard thing to get timing right, and from knowing what's going on in a person's life and that this is going to actually work.
Yes.
Yeah. In line with all these questions about time, I want to broaden, kind of still in line with the same topic, but broaden a little bit a question. It's not about timing, it's not about cyclical or sustainable effects, but what about overlooked long-term effects? So it's particularly important. So, if positive effects fades out, it's kind of sad, but it doesn't harm so much with respect to a situation which, for example, that Alia, I think, presented this topic when you said that, stress is enhancing and it's boosting your productivity. Okay, for a week, but what if it ends up being committing suicide in a year? Yeah, it's kind of very dramatic effect. Or, we reduced calories, that's really cool. But what if we reduced also intake of iron or fats or fibers or something like that? Or we increased the intake of some chemicals that are not good for our health? So the responsibility for long-term effect is really important. And I understand it's a problem in research. It's really difficult to assign these long-term effects. But how do you try to look at these long-term effects? And if you do, how do you measure it? How do you follow up participants for longer time?
So if I were to summarize, I think what you're worrying about is that sometimes we leave things unmeasured that are not the target variable. and that they can be shifted by our interventions too, perhaps in harmful ways. And so you're sort of asking, how do we think about that as scholars? Have any of you all spent time thinking about that in your research, or seen research that you think does a nice job with it?
That issue comes up with food studies and eating, right? Where you have, maybe you set up a restaurant lab and you find that some intervention causes people to consume fewer calories, but then you don't measure that when they go home, they binge eat. And so there are ways of, it's a really important issue that you bring up. It's something that we as researchers need to be aware of and think about the things we don't normally think about, right? You don't notice the dog that doesn't bark. And in that area of research, there are ways that researchers have thought that through, where they'll try to bring people back the next day and have them give a 24-hour dietary recall. Now, that's obviously not perfect, but it's really important to incorporate the point that you note.
Yeah, I don't know if I explained it as clearly as I could in the 5 minutes, but the study in which we found that people consuming the shake that they believed to be lower calorie actually resulted in a lower ghrelin suppression, which relates to slower metabolism, right? So, that study probably changed my, dramatically changed my thinking about how to manage my weight, right? Because normally we go around trying to reduce the amount of calories. But what that suggests is that if we're going around trying to reduce the amount of calories and we're putting ourselves in this mindset that we're dieting, that we're restraining, that we're, basically not getting enough food, that mindset might be counteracting all of the hard work that we're doing to diet, right? Same is true with stress. A lot of the public health messages say, you need to exercise more, you need to stress less. That's intended to be motivational. To the degree that it is, that's a good thing, but it's also creating messages that might be sort of pervasive and kind of undercutting our good efforts. And there has been some really important work done on stress and mortality, showing that people who have high levels of stress over time, it's only those who believe that stress negatively affects health that die to a greater degree when they have high levels of stress. So there's some longitudinal data that suggests that this can get in under the skin and be very, very pervasive.
Yes.
Hi. I'm afraid I'm not ready yet to give up on sustainability. So I was wondering if there are any studies on regular people, those lucky few who can sustain behavior change, like to find out what kind of strategies they use or what kind of mindset they get into. Like how do they do it? Because there are people who can do it.
Really, I think the way you said it, like there are small numbers of people who are successful. I don't think that I wouldn't put it like that. There are a lot of people who are successful. Like if you look around, it's true that 2/3 of Americans are overweight, but 1/3 of them are not overweight. And there are a lot of people who go to the gym, and there are a lot of people who consistently maintain these kind of behaviors, and we're basically never seeing them. Because if you say we see, even in the stuff that I do, we see people who are successful, but those people who are more successful, but those people are already diagnosed with diabetes. They're already unsuccessful in some way. We're not seeing the people before. And I think that understanding, is it just that some people have a lot of resources or they can eat anything? My husband will just eat whatever he wants and he's never gains any weight. Is it all just people like that who you hate? Or maybe there's people have some other, characteristic that's helping. And so I think that that's an incredibly important area to sort of push forward to try to understand more about the success stories sort of before we see them effectively.
In some domains, we see systematically better results than others. So, for example, when you try to help people quit smoking, if they are successful at not smoking for a year, the vast majority of them are able to stay smoke-free thereafter. And I think a lot of that is reinforced by the way the built environment has evolved in ways that reinforce the decision not to smoke. But when we've looked at long-term weight loss, it's just really, really challenging. So a study that Leslie and I, with others, have coming out shortly, you look at people who join Weight Watchers, and the percentage who achieve clinically significant weight loss who have sustained that at a year is nearly 0%. So I think, as Emily points out, in some sense, the optimistic view is that the successful people aren't in these programs, and have better habits. But the challenge for all of us is to really think about how we take people who don't have great habits and somehow shift that, and that's really difficult in some of these domains.
Second row, white shirt. I don't know your name. I'm sorry. Yes.
Thank you. And I want to bring the structural issue in health in again, because I think inequalities in health outcomes is the result of a lot of social determinants which add up over the life course and can have huge effects on life expectancy for each and every one of us. So I think combining that, I think it's important to have a broad conceptualization of health, in that it's not just the health sector that contributes to health, but determinants in other sectors as well. So actually applying behavioral insights into other sectors such as diversity and the workplace is quite key to bettering population health. But it's also not just the patient. I mean, in this session we've been talking a lot about the patient, but an object of nudging would also be the healthcare providers, because we know that there's biases in the way doctors, for example, meet poor patients, which can actually translate into better, worse health outcomes. So I would have liked to see much more work being done on, for example, adjusting clinical guidelines to reduce bias, for example, for certain chronic diseases that we know are disproportionately effective for example.
So I think the reason we don't talk that much about that is really hard to get doctors to do anything. It's like his family, is like, and so I mean, I think realistically there is work, not so much in that space, but in something like trying to get doctors not to prescribe antibiotics for upper respiratory infections, which is like a well-known thing. You shouldn't, don't give the kid penicillin every minute. And there's some success in interventions, but they're really quite, it's really quite hard to get people to change clinical practice. And I think this type of thing, which is even more than that, because it's like you should change the way you interact with people. I think that even designing those kind of studies is like an incredible challenge. And so I think it's a very important challenge, but I think there's a sense in which that's why it's been so difficult.
Peter, you're more in that space though. Do you have? I agree. You just agree? Okay. All right, that's a little depressing, but yeah.
So I was just wondering, as the previous question was being asked and answered, if there is work that's sort of parallel to the mindset work in intelligence to mindset work in like fitness or health, where people just get a sense that my level of fitness is just, it's like a fixed thing. Like I could, if I worked really hard, I could ace this test, but really as a trait, I'm an unhealthy person. I'm not going to be fit. Whereas other people might have this mindset that like, oh, my level of fitness can grow over time, and one day, this will be a lot easier. It just seems like I would approach health very differently if I believed that my general level of fitness / health or whatever, where like if I'm Emily's husband and I'm just like, oh, whatever. It's like I was born with the highest level of health, whatever, and now I don't have to worry about it. Not people are going to be born with some less favorable circumstance, right? Is there anybody?
It's funny. I don't think I've seen that exact study done, and it's such a low-hanging fruit. It should be done. I do know that Claudia Mueller's done some really good work with children in a pediatric population, and finds that when she shifts their mindsets about a diabetes diagnosis to viewing it more as something they can grow, they can change, they can actually become non-diabetics, that they're far more adherent to their regimen, etc. We also have a paper that's not yet published, but I think I can share it here, where we give people genetic information. Now there's a lot of different genes that relate to, how you have the obesity gene, or you have the gene that makes you have high VO2 max, and I won't go into all the results now, but one that we find is whether or not people receive good or bad information, that they're at risk or protected, that leads them in both cases to believe less in their behavior. So to feel like their behavior matters less and to feel less in control of their health. So with this precision medicine push, all of that's really important to understand that, but we need to be careful about how we're messaging genetic information.
I would just add quickly on the exercise front, I would say the key thing we know is that people are too optimistic about their ability to change. So people are wildly optimistic that they're going to be successful in the near future with exercise routines. So it's less about being sort of permanently pessimistic that I'm immutable.
My question is whether or not, I can imagine that being local, right? I believe that if I work really hard over this 3 months, I can make this big change, but that I have to because I am genetically or in some other very permanent way just not prone to being healthy, right? So that's where.
It's a great question to end with. Thank you guys all for being here, and thanks for this amazing panel again.